the chat box so that we can keep track of everybody who has been on the call. So it's almost time. So other colleagues will join us as they come in. I want to take the pleasure to welcome all of us to this October LabCoP session, which we have already advertised, and I'm sure you know what the topic is about. I want to take the pleasure to welcome everybody who is already on the call. I already see quite a number of people, a number of hubs. I've seen Zambia is online, Ethiopia is online, Malawi is online, a couple of others that I may not be able to mention everyone, but I just want to recognize everybody who is on the call this today. And today, as we advertised, we are discussing management of non-suppressed patients. And as you know, the theory of as an entry point, because there's a lot of focus of the use for viral load from the global platform, and countries are being supported to scale up viral load. So for the meantime, we are focusing on viral load, but using a systems approach. This way, we have the chance to actually handle laboratory strengthening using viral load as an entry point. So when you look at the viral load cascade, it actually addresses all the laboratory strengthening issues that one would want to consider. When you look at the viral load cascade, right from demand creation to result utilization, you realize there are quite a lot of, in that cascade, there is from demand creation to sample collection to sample transport, sample collection and handling, sample transport, laboratory testing, results, return and utilization. There is monitoring and evaluation. All this within there are lots of cross-cutting issues. As you can see down here, all the cross-cutting issues that have to be considered, all that put together would actually embrace all the laboratory strengthening issues that we want to discuss. But for this session today, we are going to be discussing result utilization, especially management of non-suppressed clients, which is quite problematic for many countries. And we are delighted today to have a subject matter expert from CDC Atlanta, part of the care and treatment team, Dr. Pati, who is going to be taking us through this session. Then we will react at the end of the session. Then I will also have some communications to make at the end of the session. So for now, I would want to open up the session by inviting Dr. Pati to actually share the screen and start taking us through the slides. Otherwise, I know many members are still joining. I want to take the pleasure to welcome all of them. Dr. Pati, please take the floor and share your slides so that we start.
Thank you, and good morning and good afternoon to everyone. I am Rituparna Pati. I'm an infectious disease doctor at the CDC, and I am part of the adult HIV treatment team in the Division of Global HIV and TB at the CDC in Atlanta. A large focus of my work actually is in supporting countries to scale up viral load with efficiency and quality, and to help them achieve the third 90. So as we all know, achieving the third 90 relies not only on viral load testing coverage so that every patient on ART has access to routine viral load monitoring, but also on the correct utilization of the viral load results. Clinical providers are critical to this step of correct utilization. They must have access to the viral load results in a timely fashion, and they must have the knowledge and skills to interpret those results correctly and then communicate the significance of those results to patients. And then following that, they really need to initiate the next clinical decision steps in order to impact patient management and have an impact on patient outcomes. It should be acknowledged that the simple act of a provider explaining the result to a patient is a potent intervention in itself. So what we mean by that is that even for a suppressed patient, a patient who has a viral load less than 1,000, the provider should congratulate the patient and thereby reinforce good adherence. And it's important to note that they should refer the patient to what we're now really promoting as less intense models of care so that the delivery system can really be more cost efficient and really be sustainable over the long term. For patients that have a non-suppressed viral load, so viral load of greater than or equal to 1,000 copies, urgent action is required, and we will talk about what actions actually should be taken in more detail throughout this presentation. But first, just a reminder of why it's important to act so urgently with these patients who have persistent viremia. And that is because they are at risk of disease progression and of transmitting HIV to others, and furthermore of accumulating HIV drug resistance and thereby having decreased chances for resuppression. There are multiple studies that show that up to 60% of patients resuppress after a detectable viral load. So this means that action actually does have impact. All non-suppressed patients really should be prioritized for urgent action. But even within this group, pregnant and breastfeeding women deserve special attention because of their risk of transmitting to the child. So we would say that this population really should have viral load measured more frequently than the general HIV population, and really with the goal of achieving an undetectable viral load. Viral load samples that are drawn from pregnant and breastfeeding women should be prioritized for processing in the laboratory. And similarly, when the result is returned, the result should also be marked as one from a pregnant and breastfeeding woman so that the facility can immediately triage this result and call attention to it so that providers can take immediate action. This is really the only way to ensure that clinical action is taken urgently on this patient population to ensure suppression and reduce the chances of transmission to the child. Unfortunately, programmatic data shows that non-suppressed viral load results are simply not getting the appropriate follow-up attention and action. In Kenya, this is a study from a few years ago, this was in one review of programmatic data from Kenya, only about 4% of patients with non-suppressed viral load had a repeat viral load test. And only 1.6% of these actually occurred within 4 months. In another study in Mozambique, 35% of patients with non-suppressed viral load had a repeat viral load test. So again, a relatively low proportion of the patients. In this study in Swaziland, Of 288 patients with non-suppressed viral load, 30% did not have a follow-up viral load within 6 months of the high viral load. Of those that actually received a follow-up viral load, approximately the same proportion of patients had confirmed virologic failure, regardless of whether or not they received adherence counseling. And only 15% of those were switched to second-line therapy. So the results of these studies are fairly discouraging because they indicate that after all the hard work that is done to order the viral load test, collect the sample, process the test, even place the result in the patient's chart, after all of that hard work, the results are not being utilized to actually impact patient outcomes. So how do we address this challenge, and how can we do a better job? To help think through this challenge, I now want to present a patient scenario, and one that is not too uncommon in our clinical settings. So this is a 42-year-old woman with HIV who was started on ART 2 years ago and presents to the clinic for a routine visit. She was last seen in the clinic 6 months ago when she had her first viral load test drawn. The provider meets the patient and sees that the viral load test from 6 months ago was 60,000 copies. The patient can't recall if she was missing her medications at that time 6 months ago. And the patient's level of adherence at that time is also not documented in the chart. Today, she said that she has been taking her medications every day for the past 2 months. What should the provider do next? This is not an easy question to answer for multiple reasons. First of all, the patient, when she had the high viral load test result, was not notified of this high result. So she did not come back into the clinic until 6 months later, just for a routine visit. Similarly, the provider did not see the viral load results until the patient just presented to the clinic for a routine visit. And at the time of that routine reappearance or revisit from the patient could not recall what her level of adherence was from 6 months ago. And the patient's chart actually also does not document what her level of adherence was at the time that viral load was drawn. So there really is this disconnect or this challenge for the provider to associate the viral load result with a certain level of adherence. And because of that disconnect, it's hard for the provider to know what to do at this time. And as a consequence, the provider can't act timely and cannot act appropriately in response to the patient's high viral load result. So what is needed? What can we do to address this challenge? What would truly help is a facility-level system that supports providers in responding to non-suppressed viral load results in a timely fashion to be able to impact clinical decisions and improve patient outcomes. There are 3 critical elements to this supportive system. One is having clear roles and responsibilities at the facility. Number 2 is having a standardized system for reporting and documenting viral load test results. And number 3 is to have tools to track and manage viral load results at the facility. And we'll break down each one of these things in further detail. So beginning with roles and responsibilities at the facility. There are many details and steps to account for in order to appropriately manage the results that have been returned to the facility and that require action. These are just some of the roles and responsibilities that should be clearly defined and assigned to specific individuals at the facility. So, beginning with monitoring the return of viral load results, basically ensuring that for every viral load sample that is drawn, that the result has been returned to the facility. Then, flagging results that require action, especially the non-suppressed viral load results and any samples that don't have a result return or that were rejected. Then entering the results into the patient's charts so that the providers can react and can act on them. Communicating with laboratories regarding samples that have been rejected or results that are still missing. communicating with patients about the need for returning for a repeat sample collection or to return sooner for adherence counseling if their viral result is actually non-suppressed. And finally, communicating with providers about really when the results have returned and be able to have timely action or response to those results. Each facility really needs to think what model or how to best assign these roles and responsibilities based on the staff that they have. And here are just a few suggestions to consider. So one is that there should be a viral load point of contact at the facility who essentially serves as a liaison between the lab and facility. And this could be the same person who does this every day, or it could potentially be a rotating assignment. So certain individuals or specific individuals do it on specific days. Another consideration is to have specific roles for specific cadres. So for example, perhaps the phlebotomist is the one who monitors the return of results and follows up with the lab on any results that are missing. Then perhaps it's the adherence counselor who is the one who sorts the viral load results into the categories that require different levels of action. And it should be acknowledged that for smaller sites that have very few staff, it may be that individuals are filling multiple roles at the same time. So in addition to the roles and responsibilities, it's critical to have key algorithms and standard operating procedures, or SOPs, that really allows staff to understand what each person's role and responsibility is and the overall workflow. So for example, at the laboratory, there should be an SOP to prioritize processing of viral load samples from priority populations that we've spoken about earlier, so such as pregnant and breastfeeding women. Also, an SOP to prioritize the dispatch of viral load results that are non-suppressed so that they get immediately back to the facility so that they can take urgent action. An SOP at the facility to prioritize the evaluation of patients who have non-suppressed viral loads as soon as those results are returned. And also an SOP for the general management of patients with non-suppressed viral loads. So here is an example of the roles and responsibilities and an SOP that I saw at a very small facility in Tanzania. It was in the Lake Zone region of Tanzania. And on the left, as you can see, there's a duty roster, which specifically lists certain dates and the specific individual that's responsible for that task. Then in the middle shows job description. So this is for a triage nurse, and it clearly says what that triage nurse is responsible for that day. And then on the far right is a viral load sample workflow. So a rough sketch of what the operating procedure is in order to order viral load tests at the facility. Now, I have a better example of an SOP on this slide, and this is an example from South Sudan. It may be hard for you to read here. We will be sharing example SOPs after this presentation, and you can see that that every step is clearly described. So in this SOP, which is specifically for the management of high viral load results, it is clearly indicated who is responsible for contacting the patient about the result, how many phone calls they should attempt, within what time period, and what should be the next step if the patient is not reached by phone, and so on and so forth. So in addition to the roles and responsibilities, the SOPs, the algorithms, there should be attention paid to the format or the method of reporting results back. So this is an example from Uganda, where this is a standardized results reporting form. It's very clear and easy to interpret. The method of reporting is standardized, and the interpretation of the result is very clear. In this case, the smiling face indicates that it's a suppressed result. Then there should also be a standardized terminology for the reporting of results. So what I mean by this is that what we've seen in some national programs is that some results at the facility, some patients will have a result that's documented simply as undetectable. Other patients will have a result that's documented as target not detected. Then others will actually have results documented as less than 1,000. And so these different methods or terminologies can be confusing and more difficult for the correct interpretation from providers in terms of what action to take next. So there should be attention paid to just standardizing and using a consistent terminology for specific viral load results, and similarly consistent classification and transparency about what actually defines a suppressed versus an undetectable result. Is it less than 20? Is it less than 400? Is it less than 1,000? So this should really be standardized and transparent across the viral load testing network. This may seem like an obvious point, but it should be made that patient charts definitely need to have a field for recording not only the date of the viral load test, but also the reason for the test and the actual result. And this is, again, so that when you look at a patient's chart, you can look back and historically see and associate what the patient's viral load test result is in association to a specific level of adherence. So now moving on to specific tools for tracking and management at the facility. And I'll just be presenting, again, a few templates and examples. So starting with the viral load sample daily log. So this is a method of tracking the sample collection from every individual patient, as well as when and what the result is when it's returned. So it clearly links the collection of a sample with the return of that result. And it's a tracking mechanism to ensure that every sample has a result returned to the facility. The information that's documented here should be the same as what's documented in the patient ART register as well as the patient chart, meaning the same viral load, the results should match in terms of what dates and what the actual viral load result is recorded. The next critical tool is the high viral load logbook or the high viral load register at the facility. So this tracks patients with non-suppressive viral loads and longitudinally documents what their viral load test was, the date of it, and when they begin enhanced adherence counseling sessions, and what the follow-up test results were, as well as any changes in their ART regimens and the outcomes. This is the first page of this register, or this template that I'm showing you, and what I want to kind of impress upon you is that this is really a tool that's to be used across the facility. It's the tool that providers can use to, again, longitudinally track and ensure that these patients are getting follow-up within the expected time period. This is the second page of that register where, as you can see, that first column says the due date for the follow-up viral load. Then the date that the follow-up viral load was actually collected, what that result was, and when the results were received, and when the client was notified of the results, and then what the outcome was, whether or not they were switched or remained on the same regimen, and again, when they would be due for their next viral load. So this is really the mechanism, the driving tool that can ensure that patients with non-suppressive viral loads are getting the action, the follow-up action that they need. This is the form that would go into an individual patient's chart that, again, documents what action has been done. So in terms of the adherence counseling sessions, what content was discussed during that session, what barriers were identified, and what are the plans for management. So I'm now going to share an example of what I've seen at a very small clinic in Lagos, Nigeria. This first picture is one of an adherence counselor's personal log of what actions she's taken to track non-suppressed patients. So she keeps this, and as you can see, each patient is listed, and she, in red pen, has documented whether she's left a message for the patient on their phone, how many messages she's left, whether the patient was ultimately determined to have been deceased, or if the patient is coming in for enhanced adherence counseling. So this is her own personal record. And then she then transcribes this record into a clean, clearly documented high viral load register. So this is the register that is used at this facility in Nigeria. And it's hard for you to read all the fields here, but it has the critical information collected for each patient, which includes the date the viral load sample was taken, the date of the non-suppressed result, when it was received, the actual result, the dates of the EAC sessions, and with columns for any additional sessions, not just the 3, but columns for any additional sessions if patients need more than 3 sessions, the expected due date for the repeat viral load, and the repeat viral load results, and then finally the outcomes and any additional comments or action plans. And then what was most impressive at this specific facility was this ARV switch form. This goes into each patient's chart, where there was a review of whether or not they resuppressed after adherence counseling or whether they needed a change in therapy. So again, this is a very clear, standardized form. It has complete documentation of every viral load test and the results of those tests for this patient, clear documentation of the date that the decision was made about this patient's management and what the new ARV regimen is, or if they were maintained on the same regimen. And then also clear documentation of the consultant, the person who's making these decisions. So I've gone through really the facility level system and what are the components of that system, and just want to say that the templates that I showed here for the specific tools, such as the high viral load register or the sample daily log, are available in a document that has recently been posted on the ASLM website. It's the considerations for developing a monitoring and evaluation framework for viral load testing. And here is the link. We'll be sending this out also after the presentation, but within this document in the appendices are examples or templates of these tools. So what I focused on is the facility level system that is needed to support providers in managing patients, because the important point is that providers can't do it all alone. They need these tools and these systems to support them in the management of patients. But that being said, providers, of course, also have to have the skills so essentially, providers need to be able to provide high quality adherence counseling and be able to educate the patients about the significance of viral load test results. And in turn, patients with this understanding will ask for viral load testing and expect a result, so thereby creating patient demand for their viral load tests and viral load test results. And I can say that as an experienced clinician. It takes patience, it takes empathy, it really takes communicating and connecting with the patient and really delving into what might be causing them to not suppress, or what is really, is there an adherence barrier here or not, and addressing the correct adherence barrier and taking appropriate action. So we've found that there's really been a dearth of materials in the field to support providers and adherence counselors on providing high quality adherence counseling. CDC has worked with ICAP to develop these enhanced adherence counseling flip charts. And as you can see, there's 4 different versions, and each one is tailored to a specific subpopulation. So there's one version for adults, one for pregnant and breastfeeding women, another for adolescents, and finally one for infants and children. And each one of these flip charts is available in 4 languages: English, French, Swahili, and Portuguese. And I've provided at the bottom a Dropbox link to these charts. They are available to adapt to a country's specific context, and then for printing and further dissemination. So now, putting it all together, let's go back to our original patient scenario and to see how her care and management could potentially be optimized, and showing an example of really how the roles could be assigned at the facility and how the tools can actually support the tracking and management of her care. So here is what we would call perhaps an optimal scenario. So this is a 42-year-old woman with HIV who was started on ART 2 years ago and presents to the clinic and has her viral load drawn for the first time. She denies any missed doses of ARVs in the past month, and this level of adherence is documented and dated in her chart. 2 weeks later, the patient's viral load results are returned to the facility, and the phlebotomist documents the date of the return of the results in the viral load sample daily log. The phlebotomist then gives all of the results that were returned that day to the viral load point of contact, who in the case of this facility, at this facility, is an adherence counselor who then sorts the results into 2 piles, one of suppressed and the other of non-suppressed results. This patient's result is 60,000 copies and therefore is placed in the pile of non-suppressed results. That same day that the viral load result is returned, the viral load point of contact locates the patient's chart and contacts the patient with the result. And this is all according to the SOP for management of patients with high viral load. The POC schedules the patient for adherence counseling and tells her not to wait in the queue, but to go straight to the adherence counselor's desk when she arrives in the clinic. The point of contact then enters the patient's information in the high viral load logbook, completes a high viral load form, and places that form in the patient's chart along with the results form. Later that week, the patient meets with the adherence counselor as scheduled, and the counselor documents the session in the high viral load logbook and also in the high viral load form in the patient's chart. After several weeks and a series of adherence counseling sessions that explored and addressed the patient's barriers, the adherence counselor informs the provider that the patient's adherence has improved. The provider meets with the patient, confirms the good adherence, and completes a viral load requisition form to order a follow-up viral load test. After 2 more weeks, the patient's result is returned and is now suppressed. The point of contact places the results in the patient's chart and then documents the results in the high viral load logbook as well as the high viral load form. And we can say that these are hopefully the last entries for this patient in these high viral load registers and high viral load forms because she has successfully suppressed. Thank you for your attention.
Charles, you are muted.
Dr. Pati, thank you very, very much for that very elaborative, action-oriented, and very informative presentation. And the fact that the tools that have been shared are actually available for the members is a big plus. The members will be able to check out the links, get these tools, and try to internalize them and see how they can adopt them to suit their circumstance. So So it is a very action-oriented presentation and quite informative. Thank you very much. So I open up the presentation to the discussion, to the entire audience to react in terms of giving you experiences as well as asking questions. I know a lot of interaction has been happening on the chat, and I will ask Nicholas to be reading out the questions that have been appearing on the chat. But also, if you have a question, you can also flag, indicate that you want to actually be given the floor to speak. Thank you very much. So Nicholas, read out the questions.
Okay, thank you very much, Chair. The first question is from Dr. Pasco, and she's asking that out of curiosity, what are the respective countries using as a cutoff for viral suppression? Is every country using 1,000 copies per mil? But she's asking what the different countries are using as a cutoff for viral suppression and whether every country is using 1,000 copies per mil. But maybe we shall tag that one with another question still from her of is there any difference between detection of instrument and a cutoff to define biological failure? Is there any difference between the limit of detection of the instrument and the cutoff to define biological failure? What do the experts from the group think? Those are the two questions that are corresponding from Dr. Pasco.
Yes, thank you, Nicholas. Actually, the last question is, there is a difference indeed between the limit of detection of the instruments and the cutoff that is used to determine viral suppression or virological failure. And I just could feel that there is some confusion maybe going around, the audience. So if one expert or maybe Dr. Pati can provide the right explanation, and maybe other people want to comment on that. Thank you.
So I can certainly comment that yes, there are different instruments that have different cutoffs in terms of the limit of detection. So I think, as clinicians, what we would say is that, first of all, I think there's a difference between undetectable versus suppression. Okay, so I think that needs to be recognized up front. So an undetectable is directly linked with what the cutoff is that the instrument can detect in terms of level of viremia. So that is where you get, if a machine is reporting, less than 20, that means that the machine cannot necessarily, report a number to detect any viral load less than 20 copies per ml. So that is what is meant by undetectable, whereas suppression, internationally has been, there's different standards for defining what is meant by suppression. And I think we often link, or the current practice is to really link the limit of suppression with what evidence do we have in terms of being able to transmit the virus. So at this time, we have minimal evidence that viral loads less than 200 can actually lead to transmission of HIV disease. So in certain settings, viral load suppression is defined as anything less than 200 copies per ml. That's the threshold, at least, that's used in the United States. Now, different countries may have different limits of that. And of course, internationally, we've used the cutoff of 1,000 because that has been tied, that's directly linked to the use of DBS and really what is the threshold for detection when we're running samples from DBS. And so at this point, that limit is 1,000, or for that reason, the threshold has been defined as 1,000 copies per ml in terms of defining viral load suppression. But I think we often We use the term undetectable as less than 1,000 when in actuality, in most settings, it's, when you're not using DBS, you can actually get much lower than that. So I hope that clarifies something. I'll let others comment and join in.
Okay. Yeah, Chair, the other question is from Daniel Kimani, and is asking, how do you standardize the viral load reporting when you have different testing platforms with different cutoffs, e.g., CAP-CTM with copies less than 2, with copies less than 20 per mil, and DBS with copies less than 835 copies per mil. Once again, he's asking, how do you standardize the viral load reporting when you have different testing platforms with different cutoffs? For example, CAP-CTM with copies less than 20, and then DBS with copies less than 835.
Yes, so that it's difficult. I can see what that challenge would be. I think it's just important that the providers understand what the cutoff is and what it means. So, the purist in me would say, report the results as what has been reported coming out from that specific machine. So if one machine is reporting less than 20 and in another region of the country, you're using a different machine and reports the lowest it can go is less than 835, capture that result at least somewhere, whether it's in the LIMS system, whether it's going directly into the electronic medical record. And the reason for this, to capture the actual result, at least somewhere, is to be able to do quality assurance. If you start to see high levels of, let's say, target not detected or copies less than this certain threshold, if you start to see unusually high levels of this, that would potentially indicate that you may have a quality issue with the samples or with how the instrument is processing results. But in terms of the forms that get sent out to the facilities and what the provider actually looks at, there should be, even if the actual result is reported there should be a common interpretation of that result. So as you saw in the Uganda form, there was that smiley face. So they, there's that automatic, association of a certain numerical value with the interpretation of that result. And so that's where there could be that step in standardizing in terms of, how the result is actually getting interpreted.
Then, of course, Leigh Berry from South Africa says that South Africa uses a cutoff of 1,000 copies per mil. And then Nora Berry from Zimbabwe also says that Zimbabwe is using 1,000 copies per mil. But there is an interesting question from Dr. Claudius, and he's asking that what do fail countries do if a patient with a viral result above 100 copies per mil comes after more than 3 months and the client is assessed to be currently adherent? I think this is a very good question. I'll repeat it once again. What do fail countries do if a viral result for a patient comes after 3 months and the client is currently assessed and they are adherent? I think it means the sample is sent to the lab and the results come back after so long, but maybe the patient has changed their practice and they're now taking their drugs very well. Yes, Dr. Pati, did you get the question?
Yes, I did. I'm sorry, I thought the question they wanted to hear from others on the call or from other countries that are on the call. But yes, I mean, I'm happy to weigh in. I mean, I think this is exactly what the patient scenario was that I was speaking about, or that I presented in the presentation, where again, there's this long turnaround time for after a result, after a high viral load result, and the patient comes back in after a long time, and perhaps their adherence has changed. So, you know, the immediate response would be, well, check the viral load again. And I know that's not feasible in all settings, but if the adherence pattern has changed, then you'll want to make sure that the patient, that the viral load is actually reflecting that. So that would be the best practice, is to collect another viral load when that is reflective of what the level of adherence is currently. But this is why, it's not going to be feasible necessarily to always be checking the viral load with each patient's visit, and if their adherence pattern continues to fluctuate. So this is why it's so important to make sure that their test result is returned, and that patients are notified of that result as soon as possible, so that you don't miss that window, because you want to make sure that you're using or testing the viral results after there's been an intervention, or after there's been actually a change.
I'm muted, sorry. Nicola, sorry. Let me unmute. Nicholas, do you still have questions on the chat?
Yeah, there are still more questions in the chat, and Ellen.
One, maybe as you sort them out.
Okay.
Maybe let's also a scenario, assuming a patient had 10,000 copies and comes for adherence counseling, and after 3 sessions is tested and they have maybe 1,500 copies. What would you do for such a patient?
I would probably, so again, it depends on the setting, but continue with adherence counseling and do a follow-up viral load. Once again, the adherence is determined to have been improved. Well, you said the first one was 10,000, and then the viral load goes down to 1,500. Okay. So, and I know we also speak about changing, having a timely change and not delaying the change of therapy if a patient does not resuppress. So, this is it's a tricky call, but this is where the clinical skills come into play. So I think, again, the providers really have to determine if the patient has been completely adherent or not. That study in Swaziland, what I showed you, showed that in most circumstances, providers, when they saw that the patient did not resuppress, they just referred them to more adherence counseling. And that's actually what my initial reaction was for this patient as well. It's like, okay, their viral load has gone down, it's improved. So maybe they're being more adherent, but maybe they're not being completely adherent. And maybe we need to check it again before switching to second-line therapy. But that again, has to be decided on what the provider can determine in terms of, do they really feel like adherence is the problem here, or, was 3 sessions enough? Did you feel like you made progress with that patient? Did the patient actually show signs that they've improved adherence, or is there still, is there more to be done? If they're not being 100% compliant, then there's more work to be done. If you believe that they've made every possible change and that they are being 100% compliant, then you should not delay, and you should just immediately switch their therapy, because you do not want them to continue on therapy that is not effective for them.
Chair, Blessing wants to say something. Blessing wants to say something. Yeah, if you want to say something, there is that function that you can raise up your hand and then you'll be seen. And if you don't know where the function is, you can do like Blessing and do like this. Yeah, thank you very much.
And I do want to go back to the previous question just for a minute, because I think the question was also about, in most settings, what are most countries doing when there's been such a long time and patients have had a high viral load results a long time ago. In most settings, I would say they're just proceeding with the algorithm. They're not doing the repeat viral load test result. They're just referring, whenever the patient comes back in, they're starting adherence counseling at that point. But that, unfortunately, that really delays things. And that's why we see that so few patients have a follow-up viral load in any short amount of time. So if it's already been 3 months since their last high viral load, and it's been 3 months and they're just starting adherence counseling now, they've lost all of that time, those 3 months to have, if they had come in sooner, they would have been able to start adherence counseling 3 months ago. So unfortunately, that's what we're seeing in most settings, is that patients are coming back after 3 months, then they're starting their adherence counseling, then it's another 3, 4, 5, 6 months before they get a follow-up viral load. And in many cases, they might not be resuppressed. And so by that time, you may have a patient who has developed resistance and can no longer resuppress on the same therapy. So just wanted to make that clarification.
You are muted.
Blessing is going to come on, but I also want to pose another question over the limit of detection. You said the cutoff of 1,000 was done because of DBS, where the limit of detection is well close to 1,000. Is that the only reason, or there is a more scientific reason beyond? Because you say in the US, it is below 200. That's where they know that the risk of transmission is reduced to nothing almost. What other reason does lie behind 1,000 scientifically? So then Blessing also come up, please, with your question. Blessing. Is Blessing hearing?
Did I raise a question? A hand?
Okay, I think I'm seeing Daniel Chimani raising up the hand.
I actually want to build up to Charles' question and ask about the limit of detection in relation to the new concept of U equals U. How are we going to apply this with the high cutoff of DBS? Thank you.
You are muted, Ritu.
Okay, sure. So, so to address that first question about the cutoff of 1,000 versus 200. So, so let me also say, most studies have also shown we don't have a whole lot of evidence that transmission has occurred for viral load copies less than 1,000 either. Okay, I think what the lower cutoff in the U.S. is more linked to what we've seen, that what we call viral load blips. So values between 200 and 1,000, patients who have low-level viremia seem to have a higher risk of ultimately virologic failure. So seem to have a higher risk of developing HIV drug resistance and ultimately failing on the current regimen. So that is the data that we currently have, that low-level viremia can lead to higher risks of virologic failure. And I think regarding U equals U, that's a very interesting and timely question. Right now in PEPFAR, we're really considering how to, I guess, disseminate, how or if to disseminate this campaign, given the, the cutoff of 1,000 versus a lower cutoff in terms of what defines undetectable. So, we recognize that plasma, for most plasma samples, you can get a much lower cutoff that actually defines true levels of being undetectable, whereas with DBS, at this time, we really can't have a cutoff that's lower than 1,000, but it would essentially be not entirely accurate to call any values less than 1,000 undetectable. So I think right now we're still trying to resolve that, but all I can say is that, we certainly are seeing the positive impact of the U campaigns in certain settings, really in terms of addressing stigma and promoting awareness amongst HIV positives, especially amongst the key populations, raising their awareness of how important it is to access viral load testing, get their viral load results, and ensure that they are undetectable.
Okay, thank you very much, Dr. Pati, and for the audience for that very interesting and interactive discussion that we have had. I'm sorry we may not be able to continue with questions because time is running out and there are a few announcements to make. But the session has been recorded. So for the people who have not been able to be on the call, please you'll be able to access this recorded session just like a few days. Our team, I think 1-2 days, should be able to upload this on YouTube, and you should be able to receive it. But of course, the discussion should continue on WhatsApp. The good thing is WhatsApp never closes. It's 24/7. So please, even at midnight, you pose your question. By morning, you have an answer. So please continue with the discussion on WhatsApp. And the tools that have been shared are going to be uploaded on the website. Some of them have already been uploaded, but we are also going to share them on mail. We are going to share the links to you on mail and WhatsApp so that you can have these links readily available to you for you to click and receive these very valuable materials that we use to improve our program. Thank you very much, Dr. Pati, and for the entire audience. So I want to make a few announcements. First and foremost, I want to welcome people back from the face-to-face meeting. Those of us who were in Kampala, we had a great 3 days of very interesting interaction. And I hope when we got back and relaxed a few days, we got back into business. We had some unfinished business, which was the action plans. So we did most of the bits of the action plans, but we had to go and re-engage with the stakeholders, especially finalizing the bits around funding for the action plans that we had come up with. So we request you to actually do the final touches on the action plans, engage with your stakeholders, look for the funding within your framework, whether you mainstream within your COP planning or your global fund programming and reprogramming. Make sure that we can find funding for our action plans that we are developing, because we are not only developing for the sake of it, but we are developing for implementation. Remember, we are focusing on demand creation and result utilization. So actually, this presentation today by Dr. Pati has been spot on. He has given us a lot of implementable interventions that we could put in to enrich our action plan around result utilization. So please pick these pieces and enrich your result utilization action plans. And we want to finalize this. You know, we have the ASLM 2018 around the corner, beginning on the 10th of December up to 15th of December. But a day before, as a curtain raiser for the conference that is happening beginning on the 10th, we shall be having our satellite. We are going to have a LabCoP satellite happening on the 9th of December. It will be a whole day satellite, but our focus will be on catching up with what we did in what we did when we were in Kampala for the face-to-face meeting. We are going to be seeing progress around action plans and their funding, but also the implementation. Out of this meeting, we want to come up with implementation plan for those of us who will not have been able to do an implementation plan by the time of this meeting. So please work on your action plans and finalize the action plans. There have been lots of questions coming out, how people are going to come to Abuja. We are planning within LabCoP to ensure that we will be able to support about 2 to 3 people from the country team who are going to come and share their progress on the country action planning. And lots of catch up that we will do, catching up with what we finished, what we left unfinished by the end of the face-to-face meeting. I don't know whether Dr. Pasco, you have some communication to pass before I close out the session completely.
Well, thank you, Charles. I think you provided a good overview. I think we are already a few minutes over time. So I just would like to invite the countries really to come at the session of November, because our colleagues from CDC will provide an overview of biosafety, biosecurity, waste management. And this will be a starting point for following up with individual country and help you to set up your waste management and really follow up with you. So please be present. It will be very interesting, and it will be a kind of a first, because there will be parallel session of those ECHO and training where people from the facility in your country will be able to be trained on biosafety and biosecurity. Thank you.
Okay. So look up to the information and advertisements that we shall send in the course of time around the November session, and you have received the heads up on what we are going to be discussing. So wait out, keep watching and keep ears on the ground for it. Otherwise, I want to thank you all for this very, very interesting session. And thank you for our guest speaker for such a very educative and informative session. Have a nice evening, nice morning, and nice day. Bye-bye.